I would like to invite our speakers up to sit on the panel for question and answers.
So the first question is the relationship between EGIDs and GI motility. Does esophageal dysmotility / spasms make EOE worse, or do spasms occur because of the EOE, and how do you treat it? So maybe one of you GI guys wants to take that, since it's dangerous to see an allergist.
Antihistamines. So I think it's a often asked question, is the swallowing problem due to spasm of the esophagus? I'll tell you, spasm is an overrated problem. It's overdiagnosed. Many times when patients have difficulty swallowing, we call it a spasm of the esophagus. But in my experience, most of the difficulty with swallowing is due to these fibrostenotic problems. It's due to these strictures or the narrowing of the lumen, the narrow caliber esophagus. It's not due to a muscle spasm. There are patients that we've had that have spasm or even an achalasia. It's a special type of motility problem, but they are few and far between. The majority of patients, we don't see problems of the motility. The problem is the structure of the esophagus, where you get these strictures in the esophagus.
This is an area that really hasn't undergone the investigation yet in pediatrics, and I think Ikuo's slide was great because it showed this gradient or differences in both symptom presentation as well as what may happen over time. So I think within children, we don't know yet. There are some suggestions that there may be motility problems, and is that more reflective of this immediate inflammation that happens, and then we see a maturity or a change in that over time to patients who have had strictures. So I think we're still learning certainly about this in children.
I don't know if you would call it necessarily a spasm, but Glenn, your paper with Sam Nurko that showed that kids complain of dysphagia symptoms at the same time that they could see that there were motility problems going on in the esophagus. So that makes you wonder if there are some differences maybe between the causes for the complaints in a child versus the causes of the complaints in an adult patient.
The other thing that can happen is when food is stuck in there, like you get that food impaction, the esophagus will start to contract like crazy. It tries to push that food down, and you'll start to see these high amplitude contractions, these very high pressure contractions, trying to push the food out, and that becomes uncomfortable. That's when you start to feel pain in the chest when the food is stuck. So that can be a secondary motility problem related to the food getting stuck in the esophagus.
So the second question that was pre-submitted was, if it's not a food-causing eosinophilic response, what is it? It's a large open-ended question. It can be anything from all the things we have to rule out to show that it's not EOE, whether it's reflux, celiac disease, Crohn's disease, inflammatory bowel disease, parasitic diseases. All those other things can cause eosinophilia, including even aeroallergens, but you have to rule out all the other things. There's lots of things that can cause an eosinophilic response besides, especially in the esophagus or even elsewhere in the GI tract. I mean, allergies in general cause eosinophilia. Other things can cause eosinophilia. Eosinophilia is not a, it's a cell that can come from any of inflammation, including allergy. Anyone else wants to add? The third question, do doctors and researchers think there's a link between EGID and GMOs, genetically modified organisms and foods? What role does environmental allergies play in corresponding symptoms? My son's the worst in the spring, so I mentioned this. I answered the second one already, so the first one I'll pass off to someone else if they want to. They won't monopolize. Does EGIDs have any relationship with GMOs?
I don't know we have any data for that yet. I think we're really still trying to understand, as you could appreciate from some of the presentation, just the very strict epidemiology of the disease. Who are the patients? What are their complaints? And now we'll see this hopefully second wave of research that's going to really help us think about where do the patients live? What kinds of things might they be exposed to? Are there certain things that they may be exposed to that are going to help us understand? It'll be a hard question to answer, but perhaps studies like Dr. Aceves is doing right now with respect to exposures may help us to understand that better, but I'm not aware of any literature yet on GMOs.
There's a lot of questions about why this disease started and why did it emerge over the past 20 or 30 years. I think that's when people start to look at, is it our food supply? Is it something environmental? Is it pollution? Is it food preservatives? Is it something that we've done to process the food? And I think that's why these kind of questions come up about something environmental that changed, and was it the way food is processed? I think that's why there's a lot of speculation about this, but again, there's no data to prove that that's why we're seeing so much EOE now.
We're going through the pre-printed questions. Do you want to answer the PP? To that question?
So there's a question about long-term use of proton pump inhibitors, and I guess there's two ways to approach this. One is, why use them, and are they helpful? And the second is, what about long-term use? I think there are at least two uses for proton pump inhibitors in patients who have esophagitis. One is to make a diagnosis. So we use it as a diagnostic test as much as anything else. As you saw in the algorithm by Dr. Hirano, treat to make sure that reflux isn't present, treat to see if the inflammation goes away. And so as a diagnostic in a short-term period, I think it's relatively safe as a diagnostic test. The second part of the question, I think, is for long-term use, what are the issues with that? And I think, as with anything else, we have a growing body of experience when you've had decades now of using a medication, probably more in children than adults, and what are the problems, infections on either side of the spectrum, older and younger. There's an association with bone demineralization, and I think what we're making are associations now of medications in large populations of patients who may have alternative uses. So are reasons for having problems. So I think there are potential issues that could come up with them. We always watch. We always try to wean off of medications that we don't use. But I think in many patients, they're very helpful for concomitant symptoms, even if you have strictly eosinophilic esophagitis.
If it's okay, I'm sorry to interrupt you. I'm going through the questions that came in too, so I'm going to try and lump them together so that they can get answered maybe together. Otherwise, we won't get through even close to half of them, I'm afraid. In terms of, there's also questions about long-term effects on children, which Dr. Furuta talked about. And if you're using concurrent steroids, like for asthma or eczema, along with EOE. And then also whether you can continue to use Splenda for eosinophilic kids, and what kind of monitoring needs to be done. So, sorry, Ikuo, if you want to touch on any of those topics with your answer as well.
I was just going to echo something about the long-term PPI therapy. So just keep in mind, it is considered one of the safest class of medications overall. It went over the counter, in fact. You got the Prilosec and Prevacid over the counter. There are potential long-term side effects, including calcium absorption issues and potentially even B12 deficiency, but they're really, really rare. If you look at the series, it's 1 in a few thousand patients that are at risk for these potential side effects. So generally, I consider PPIs a very safe class of medications, very effective for many patients. We don't know why they work for some of these patients. There's speculation about why they might be long-term, might be effective. Our own experience has been different, a little bit different than what Dr. Aceves mentioned. We've actually had long-term success with keeping patients on proton pump inhibitors. Not every patient, but many of our patients have been kept on PPIs and sustained their response longer term. So I think they can be an effective way to treat what looks like EOE, and we don't exactly know why they get better.
And I think, one of the things too is that there's probably interplay between these diseases, and we also don't know if, for some patients, can you send it into remission with a combination of therapy and then maintain with just an acid blocking medicine or a PPI? We really, don't have any answers about that. Sort of as clinical practice for our kids now that have been on either long-term topical esophageal steroids, or who are on multiple topical steroids, so one for asthma, one for EOE, one for eczema. We have started doing DEXA scans, so those look at bone density. We haven't had too many of them done yet, but most of them have been normal. In fact, there's only been one. I can discuss that later, but so the vast majority look fine. The other way that we check for side effects from steroids is to do an AM cortisol on our kids whenever they get an endoscopy. So that looks to see if your cortisol is low, it means that steroids are being absorbed into your bloodstream, and we haven't ever seen that. So we hope that these topical steroids are pretty safe and effective. They've been used for a very long time in asthmatic patients. But there's always a lot of really important questions about, how long can you use them, and is it's safe forever, and then the interplay between acid and allergies.
As a global statement too, I think what we're all trying to do is balance out risk and benefits. So what's the goal? And is the goal going to be getting rid of all the eosinophils? Is the goal improving quality of life? Is the goal to relieve symptoms? And then how does this match with what the symptoms or with the treatments that we're going to be using? And I think the quality of life issue has come up now. So, regardless, it's chronic disease, needs to have treatment. How do we balance things out to make sure we can maintain growth and development for children, and I think improvement in quality of life overall?
One thing about the long-term topical steroids, as Dr. Aceves mentioned, is certainly there have been no signals other than the thrush, the yeast infection, which is almost never symptomatic. That's the one signal that we're seeing with long-term topical steroid use. Other things are being monitored to make sure that these are safe, but there have been no reports to date of any long-term toxicities of the swallow. Of course, it's not a lot of long-term experience. However, I think you'll see that most of your practitioners that are giving you these medications, the topical steroids, are trying to usually reduce the dose down. So once we get you to feel better, many of us are trying to reduce the dose down to the lowest dose that will keep you quiet, that will keep the disease quiet. So you'll see going from twice a day to once a day, or double strength to half strength, and that kind of approach, trying to minimize any potential long-term risk, even though we don't think there are major long-term risks.
Aren't weaning off them a whole lot, and I'm just curious. I mean, we're not talking about a 30-year-old being on a PPI and going off of it at 40. And so that's just my question. Has there been an actual study of somebody being on a PPI for 40 years?
So no.
Okay, that's what I wanted to know.
So the answer is no, because no one's ever going to do that study, because that's an impossible clinical trial ever to do. But clinical experience suggests there's no major issues.
So if our kid, is going to be on a PPI for 15 years, let's just say, should we on our own just look into having a bone density done?
I think it's a reasonable test to do, and I think, again, it's always questioning why are you using it, is there benefit from using it, and then watching for side effects. Yeah.
Okay. I have a series of large stack about allergy testing and various allergy testing. So there's a couple questions on IgG testing. So IgG testing has never been studied in any disease. IgG testing generally tells me what you ate. Okay? If I test everyone in this audience, all you will have IgG foods to what you had for breakfast. Okay? It's a normal human response. Okay? We all make IgG. Your higher IgG level, in terms of IgE allergies, the higher you are, the less likely you are to be truly allergic to the food. So the higher you are, the less likely you are allergic to the food. So don't do IgG testing. It's a total waste of time and money. Okay? Don't do it. It's waste. It's useless. So that's not IgG. IgG is your normal human body response. The delayed reactions, which is what we see all the time in EOE, food protein-induced enterocolitis, is not an IgG response. We assume, we don't know, it's a T-cell mediated response, and that's what the idea of patch testing is looking at. We don't have a T-cell mediated assay. There's no great test. IgG is your normal body response. We all make IgG to food. It's normal. Okay. Well, the IgG testing is worthless. Be blunt, don't do it. You can cost yourself tens of thousands of dollars. Okay? It's completely... So there's another question called the Alka test. Now, the Alka test has potential possibilities. It's not been studied, but that's theoretically a T-cell test. Okay? So that one has not been studied at all, but that may make sense. But IgG biologically doesn't make any sense for EOE. Okay? The idea of skin tests and patch tests, just to go over, apparently I wasn't clear enough. So there are three basic tests. There's skin test, patch test, and specific IgE. So skin testing is the scratching on the arm. The patch testing is looking for delayed reactions. The skin test is IgE. The patch test is looking for delayed reactions. And specific IgE is the same as skin testing. all tests have a high false positive rate. That means your positives may not be truly accurate. Your negative, you can get false negatives. That means your negatives are not accurate, is lower. So usually if your negatives are true, if you're truly negative on the test, you're probably not going to get an allergy to that food, with the exception of milk. Milk, the test doesn't seem to work so well. But there's a fair amount of false positives on the testing. You can get skin patch testing to other things, including pollens and tapes and adhesives, but they're looking for tapes and adhesives. You're looking for contact dermatitis, like a nickel allergy. You don't do it for EOE. Let's look at that. Can you be negative to everything and still have food allergies? Yes. So those patients, we empirically just take off milk or do the 6-food elimination diet. I like to call it the 8-food elimination diet. Or actually, we do more of a 4. We're actually doing a clinical trial with them now for doing the top 4 foods. And the other question is, how do people outgrow it? It's less likely people outgrow it. It's different than IgE-mediated allergies. It seems to be occurred from a completely different mechanism. You can outgrow one but not outgrow the other. So they seem to be different in terms of food allergies. And I think I've covered most of them, and I'll pass this on to... Okay, a quick question, just a really one, we'll just do one.
You mentioned some of the alternative testing, like that Signet company in Florida that does the IgG testing.
Yes.
What about the Immunocom company that's doing MRT, mediated release testing?
So basophil histamine, so mediated release testing, I'm not sure what it is. There's something also called basophil histamine release assays, or looking at basophil activations. They're another way of looking IgE-mediated allergies. It shouldn't. No one's looked in EOE. We've looked in a very small number of patients. Less than 10 was not helpful at all. It looks another way of looking at IgE-mediated allergies. It probably has no relationship, we think, but we don't know for sure. The ends are too small. We'll pass this on.
So I'm going to pass this down to Dr. Newbury. He's got a series of questions on EG, EGE, EC. So.
Okay, one of the questions is, what are normal and abnormal levels of eosinophils in the other parts of the GI tract besides the esophagus, stomach, small intestine, and large intestine? Well, that hasn't been studied nearly as well as it has been in the esophagus. And even now, some people think a rare eosinophil in the distal esophagus may not be pathologic. Certainly in the stomach, if you see perhaps more than 15 or 20 eosinophils per high-powered field, most people think that's pathologic. Probably the same number in the small intestine. In the colon, the number varies depending on what part of the colon you're in. If you're on the right side of the colon, in the cecum, normal numbers of eosinophils are probably up to 50, perhaps even slightly more than that per high-powered field. They decrease as you go, distally as you go towards the rectum and towards the sigmoid, in which case 25, 30 eosinophils per high-powered field is probably considered the upper limit of normal. But that varies geographically. Those numbers vary geographically. They probably vary seasonally as well, and it's certainly not nearly as well studied as it is in the esophagus. When I look at gastric biopsies and colonic biopsies and try to decide whether or not the number of eosinophils are increased, some of the studies that have looked at that have actually looked at the number of eosinophils per high-powered field. Some have looked at the number of eosinophils between crypts. So the studies, as I said, there aren't a lot, and they're not all that well categorized, and they haven't looked at large numbers of patients either. So in addition to the number of eosinophils, if there are increased numbers of eosinophils in the epithelium, as opposed to just in the lamina propria, I think that is probably significant. At least I'll comment on that, although some of this is just sort of anecdotal. The studies really aren't well done. And if I see degranulated eosinophils, at least I'm more suspicious that the increased numbers of eosinophils, if you're kind of near the upper limit of normal, that is perhaps significant as well. So there's another question here. What is the minimum EOS per high-powered field for a diagnosis of eosinophilic colitis? Again, I think that depends on what part of the colon you're in, distal versus proximal. Like I said, certainly more than 50 or 60 eosinophils in the distal colon, I think is significant. That number in the proximal colon probably is within normal limits. But again, it's often not just as in the esophagus, it's difficult to say, 25 is normal, 35 is abnormal. I think there are other factors, and they said it's not well. It really hasn't been studied that well. There's a quick question here that also says, are there any nationally available training classes for GIs and pathologists? I don't know about gastroenterologists, but certainly this is. I was actually at a recent Mayo Clinic conference in the spring, and there was a session on eosinophilic esophagitis and eosinophilic gastroenteritis. So yes, it's becoming much more aware in the pathology literature and through many pathologists. So the answer to that is yes.
Yeah, and to comment on that again, I guess, especially in the context of this meeting, what we think about when we leave and we go back and do all the things that we do is who do we want to get impacted by the work that we do. So we think about target audiences. And 15 years ago or so, we said we need to talk to pathologists about this. And then it was pediatric gastroenterologists. And then it was adult GI people. And now it's coming back again, though, I think, to exactly what Rob's saying, is that there needs to be more education about many of these areas in different groups, but also identify the research that needs to be done to establish what those norms or abnormal values might be. And one of the trends that came out of this last consensus recommendation was not just to focus on a number of eosinophil. There's probably, we're trying to figure out, is there any other disease that's characterized by one cell number alone outside of cancers? And there really aren't. So we're trying to broaden this out into other features that may be present, as Dr. Newbury had discussed. So it's an important area, something that you guys can help support both from an educational standpoint as well as a research standpoint. We're trying to understand that now past the esophagus even more.
So there are a number of questions on aeroallergens and EOE, so Dr. Spergel and I can help to answer those ones. In terms of eosinophil counts in the biopsy increasing with seasonal aeroallergens, what do you do about that, and is there any effectiveness of allergy shots or oral immunotherapy? So, we think that the eosinophil counts can increase during pollen seasons. I think everybody probably does things a little bit differently, and it probably depends on the symptoms as well. So if you have a really high pollen season and you feel really rotten, I think something would be done in terms of therapies. I think if you have a very high eosinophil load and it's during your pollen season but you feel okay, my practice is just to watch it, and because the patient feels okay, and see if it resolves on its own, because I don't see a need, if you feel okay, to jump all over the histology and increase the treatment. And I can't make the pollens disappear from the air. They're going to do that on their own. And the answer may be different in different parts of the country, where the East Coast has very high ragweed seasons and people are very, very miserable. Whereas here in San Diego, we have grass pretty much 9 months out of the year. It's very temperate. So the aeroallergens that our patients see and the loads of those aeroallergens can vary. Do you want to take the one on immunotherapy?
So immunotherapy, there's two types of immunotherapy. The standard immunotherapy that everyone gets in the United States, which is the shots. So by shots, we think probably will help. It's probably a reasonable way to treat aeroallergens. So it's probably a useful way to treat it. And I don't think it will make EOE worse or better. I think it might treat your aeroallergen EOE. The sublingual immunotherapy, which is the drops, which is common in Europe and in Australia, not rare in the US, but occasionally some people do. It's off-label use in the United States. There have been case reports of that actually inducing EOE. So that one I would do. If you have EOE and allergic rhinitis, I would not do the drops. There was also a related question about immunotherapy doing Xolair treatment. Xolair treatment for EOE doesn't work. There was a report published by the NIH, including for milk immunotherapy, try to reduce it faster. It doesn't work. It's a different mechanism. It's not going to work at all for that.
Sorry. Go ahead.
So there's a whole series of questions that I like to think of outside the esophagus or outside the intestine, or what's the relationship, ranging from leg pain to mitochondrial disease to sensory processing disorders, and in autism. And I think we're right now trying to figure out who those patients are. And one of the things we think about in medicine is, are you what we call a lumper or a splitter? Do you put everything together and say it's all related? Or are they separate problems and maybe not related? And because some of these things are very common and can occur in someone who doesn't have any other type of disease, and other times they may be very rare, and so you want to try to put them together in. So I don't think we have the answers on that yet. Certainly from the autism and sensory processing disorder standpoint, Dr. Spergel and I have talked about this and have submitted some grants to try to understand just, is there a relationship? And it certainly is on the autism treatment network and autism groups radar screen of looking at food allergies and looking at these types of diseases as being associated, because then we go back again to what's the cause of them. Are there ways that you can intervene that may be able to prevent and or treat those things? So I don't think we have the answers on this yet, but there's certainly important things to consider.
Just take a couple of questions.
Moving back and forth.
One question that was, how can you differentiate between eosinophilic gastroenteritis or colitis and functional abdominal pain? So functional abdominal pain refers to a number of disorders in the gastrointestinal tract. Something that you might have heard of is called irritable bowel syndrome, or IBS, which can cause symptoms that are similar to eosinophilic gastroenteritis or colitis. It can cause abdominal pain, diarrhea, or constipation. And the best way to differentiate that is to do an endoscopy. So typically on endoscopy with eosinophilic colitis or gastroenteritis, we'll see inflammation. We'll see ulcerations or swelling or redness of the lining, and the biopsy, of course. The biopsy should be normal. If it's functional abdominal pain or irritable bowel syndrome, it should be completely normal. If it's eosinophilic colitis or eosinophilic gastroenteritis, we see eosinophils. The other important clue is a blood test. If the blood test shows you the high levels of eosinophils in the blood, then it's more likely to be eosinophilic gastroenteritis and not irritable bowel syndrome. The blood test is sensitive. About 75 to 80% of patients that have EOC or EOG will have an abnormal blood test with high levels of circulating eosinophils in the blood. Just one other question I had was, do adults ever choose to do a formula over steroids? And I would say in general, in my practice, it's unusual for adult patient to want to go on the elemental diet unless they're really severe. If patients have very severe, they've already been through the 6-food diet and they didn't respond, or they have a very severe phenotype, a very severe presentation, then they might choose to do the formula. However, many, many patients, I'd say sometimes over half the patients, are interested in trying the dietary approach rather than using topical steroids. And the reason for that is, one, they think it's a way, which it is, it's a way to potentially avoid taking long-term medications. So you don't want to take medications lifelong. You don't want to take the potential risks of steroids. So many of them choose to do dietary therapy with the 6-food elimination diet, but very few choose to do the elemental diet. So we usually start with the empirical elimination before doing the elemental diet. And then one other question was about how to avoid thrush, which is that yeast infection in the mouth. And there's no surefire way. Remember, it happens very infrequently, about 15% or less of the time it's going to happen. And usually when it does happen, it's completely asymptomatic, so it doesn't cause any problems. But one way to minimize that is to rinse your mouth out. So after you use your topical steroid, whether it's the liquid or the spray, rinse your mouth out after you've swallowed it, and then rinse, gargle, and spit. So spit out the water so it gets rid of the extra steroid in your mouth, because you only want the steroid in your esophagus. You don't really want it in your mouth.
One of the questions is, if a child is avoiding foods because of reaction or discomfort, how is the diagnosis made? Are biopsies inaccurate when diet is already limited? The answer to that latter part is yes. Certainly if a child is, if you're self-medicating or avoiding certain foods and somebody is biopsied, we may not sort of reach that, somewhat artificial number of 15 eosinophils per high-powered field. If the food that's been eliminating, that is eliminated, is the causative agent. The other thing, certainly with biopsies, is that we're counting eosinophils per high-powered field. The high-powered field on my microscope is not necessarily the same area as the high-powered field on another pathologist microscope that's made by a different manufacturer. So that brings up the pathologic question: is should we be counting eosinophils per area as opposed to per high-powered field? And the other question is, when we look at any one field, and we try to reach that magic number of 15, if you will, frequently only part of the field is full. So it's sort of an artificial number, but the answer is yes. If somebody is sort of eliminating foods from their diet that causes the eosinophilic inflammation, we may not reach a high number of eosinophils. You may see some secondary findings. You may see a small number of degranulated eosinophils. You may see some basal zone hyperplasia, but those pathologic findings may not necessarily make you highly suspicious of eosinophilic esophagitis.
So there's a series of treatment questions, especially about mixing the budesonide. If you can't tolerate the Splendas or something else you can mix it with. That's all anecdotal. Sometimes applesauce, sometimes sweet potato baby food is what we've tried. If people can't do it, there are pharmacies that will compound this for you. The only thing I'd tell you is don't have it compounded beforehand because it may not be the right viscosity. The real goal is to make it the right viscosity. There really haven't been any studies done with anything, which goes into the next question about whether the FDA will approve the slurry and when will that happen. The Splenda was really meant in our minds to be a stopgap. It wasn't meant to be a forever thing. And I wish we had the answer to when the FDA will approve it. There are still clinical trials going on now in adults looking at symptoms and using this slurry. So I'm afraid we don't have a really great time frame for you. There's a question about crushed anacort. It should not be systemically available when you treat it. There's not studies looking at how effective it is in the context of EG and EC. It does work for right-sided Crohn's disease, which is what it's approved for. Is that anything to add?
I think maybe there should be a little bit of caution about the enterocort when it's delivered. When you crush it and then you swallow it, it's going to get to the stomach, so it's really good for eosinophilic gastritis and proximal gut, like the small bowel. But there is a concern that you're going to be now exposing more of the bowel to absorb that. So enterocort, it's the capsules, they're designed to be released in the very last part of the ileum of the small bowel and then into colon. So it really is designed for ileal disease and colonic disease, but not for the stomach. So when you crush it, you're removing that interior coating and now you're swallowing it. And I think there will be more absorption to the bloodstream when you swallow it that way, when you put it in a powder. So again, it gets back to the long-term safety of steroids, and my own approach is, again, reduce the dose down to the lowest dose that is needed. So once you get a response, to bring it down, because my suspicion is that it will have more systemic effects when you crush it compared to when you swallow the capsule intact.
Thanks.
A couple questions. One is on HES, or hypereosinophilic syndrome. When you have hypereosinophilic syndrome, it's really important that you have the right diagnosis. You have to rule out all the other causes of systemic eosinophilia. It is, you also have to make sure you're monitoring various organs that can have potential side effects from high eosinophil counts, which is sort of unique to HES, which we don't see kids with like bad atopic dermatitis, which have really high eosinophil counts, don't get the cardiac involvement. Somehow in HES you do. So you have to make sure you have the right diagnosis. So you need, typically what we do, there's a whole treatment algorithm and diagnostic algorithm that's been published. Most of those patients, we end up sending them to hematology oncology to get bone marrow biopsy, and we send them for genetic testing to make sure they see if they have the specific mutation. One of the questions is, can you use prednisone a long-term treatment option? The answer is yes. We tried not to do it, but some patients only respond to that. You try various steroid-sparing agents. You try various chemotherapeutic agents. HES borders on the line. There's some variants of HES which are truly almost oncological disorders, so you need to treat it differently. But HES, just to let you know, is completely different than EGIDS. EGIDS doesn't come HES, different disease. The other question is a bunch of questions about food introduction. How soon do you biopsy and what sort of symptoms you have and when you rebiopsy? Typically when we do it, we do one food a week and we rebiopsy 2 to 3 months later after adding that food. We will often we'll reintroductory foods in groups. We'll do like all the berries. Especially if kids who's doing well, we can move things on pretty fast. We'll do like all the leaf vegetables, the spinaches and the lettuces, to do them in big groups because they tend to pass those in large groups and we can add a lot of food back fast. For other foods, the milk, the egg, wheat, soy, the top 6, we tend to do one at a time and we'll rebiopsy 2 to 3 months later in terms of those lines. And what is sometimes patients you looked up, I talked about some patients comes too symptomatic from the adding foods, you add a food back, they complain of belly pain, vomiting, diarrhea. So sometimes that's enough, that's clearly you don't need to rebiopsy, but not always. We've had patients who say they feel fine and have normal biopsies, and we have some patients who've had chronic low-grade symptoms whose biopsies are completely normal. So they don't always correlate back and forth. And the other question is, who do you work with? Do you work with an allergist and nutritionist? Obviously, someone didn't ask me, they must be seeing a gastroenterologist. It depends on who you want to work with. I think the answer is with all the above. We, in our center, and I think many other centers, have all of them there, and that's the advantage of having a center. You have an allergist, a nutritionist, and GI. An allergist to make sure you're not going to anaphylaxis the food. GI is to help with, make sure that you can do the endoscopies and deal with some of the abdominal pains, and nutritionist making sure you have an appropriate balance of, so you can eat and grow. So I'll defer. So we'll go there, and I'll pass it on to the next.
So, two comments about that. One is, and we hear this regularly, people aren't always available, I think, to help. You may not have, a luxury of having a center, having nutritionists, allergists, GI people. And so I think one important thing is have a quarterback who's going to be thinking about your child and how to take care of them, or you as an adult, that you want to have someone who's willing to be a little open-minded, because this is a relatively new area, and someone who's willing to communicate with other people to think about this. But what we've experienced now is there growing interest in this, so you should hopefully geographically have people who you can go to and turn to, but you may not have all the people together. I think certainly within all of our research networks and consortia and things, we talk a lot, we speak a lot about things, and I think the other thing I was going to say was it's great because it is like a good marriage. We agree to disagree but not be too disagreeable, and I think Dr. Hirano had just spoken about his use of topical steroids and treating so that you don't get fungal infections. We kind of do the opposite. We have our patients not eat or drink for 30 minutes, not rinse their mouth out, because we want to try to get all of the steroids down in the esophagus and make sure it has its effect. So I think we're short of time. There were a number of questions we obviously would be happy to go over with you on them during off times, but I think that was it, right?